Hello, everyone. Welcome to another episode of the Healthcare Inspired Podcast. I have my amazing co-host, Maya Turner, on the show today. Welcome to the show, Maya.
Hello.
We're so excited to be here with you guys today. And we moved everything to our lunch hour. We know sometimes it can be a lot easier to check out what we have going on your lunch hour. But if not, you can watch the recording and catch on our audio podcast on your favorite podcast station. So today we're talking about from policy to practice. We really want to talk to our audience and those of you out there in leadership who need to understand a little bit deeper as to the impact that understanding insurance policies really has on your organization. So we kind of think, Maya, right, of like our main policies, our
Yeah,
LCD policies, local
right.
coverage determination policies.
Yes.
Now, just to kind of dig back into the basics, for the most part, CMS Medicare runs the show because most payers, a lot of payers do follow their guidance. So they'll say that they follow this policy or NCCI, the National Correct Coding Initiative. But for some reason, if that particular region of the country where you're at, your local Medicare regional contractor doesn't have a policy on that, you revert maybe back to their national coverage determination if they have one for that, right? Other than
Yes.
that, you follow CPT guidelines specifically.
Correct.
If there isn't
Yes.
a policy, you don't have anything to go by other than your guidelines.
Hmm. And I think part of the issue that comes about is that we expect everything to be there. We expect,
Yes.
and you said this a long time ago with coders. Coders always stop expecting other people to do your job, right?
Yeah.
And because of that, yeah, it becomes really an issue if you're looking for guidance there isn't there, and you're looking for your leadership to make a decision and they don't have the equipment to make the decision, and they either A, don't know where to search, or B, are looking for help. And I think part of the problem is that there's no precedent. And
Mhm.
the problem is not to have a precedent. The problem is to have something in place when it happens, not just, you just have to have it there and not thinking just in case.
Exactly. And so I know a lot of people are excited about this episode because we had announced we were going to talk about some key policies and some recent updates for the Office of Inspector General, who has announced they're starting on their work plan for those hyaluronic acid injections, those knee injections that we often see with the knee, right? In orthopedic practices, and it's on their work plan. I'm not surprised. Being in orthopedics as long as I have, I'm surprised it hasn't been done sooner.
Yeah.
And then we come across other policies in orthopedics, like earlier this year, we had a revision to the local coverage determination for trigger point injections.
Yeah. Hmm.
And then we have even just something that like what kind of went under the radar. People didn't really see it as often is that our code for Depa-Medrol, one of the
Yeah.
drugs that we inject,
Yeah.
they totally changed the code structure.
Yeah.
And so it's different,
Yeah.
right? So we were
Yeah.
used to like having to figure out the milligrams and
Right.
was it 40 or 80 or what it was, and then do the
Change it to
conversion
one.
at times, right?
Yeah. Yeah.
And now it's just one code, J1010. And it's like if they inject 80 milligrams, it's hard for us to type in 80 units. Like it's a lot. So we're like, really? Is that right?
Yeah.
And it's like, yeah.
Yeah. Because they changed the code for 20 milligrams a piece to, and you would do 4. Now you're doing 8 because it's 1 milligram for each milligram that's used.
Right. So we had the J1040 and we had the J1020. And so it was either 40 milligrams or 80 milligrams. So it made sense, whatever, you were using, you would use the correct code to
Right.
account for that type of vial. But now it's based on per unit or per milligram. So it's a lot
Right.
easier, I think, as far as reading the documentation and pulling that
Right.
data out. So I think it's an easier thing, which is great. So these
Right.
are things that are changes, right? And these are quarterly changes sometimes because we know the healthcare common procedural coding system, the HCPCS as we call it, they do revise things quarterly. And so if
And
you're
so
not
does
up to date,
ICD-10. Yes.
yes. And so sometimes we have those changes that happen quarterly. and we have to be aware of that.
Right.
Other
Yeah.
changes are annual. Other changes are, um, just happen as they come. So, for instance, like when COVID was a thing, and we had all those vaccines, we didn't have them in our book, right? So we had to be on our game as to what these codes were to report the use of these vaccines and the different companies, right?
Yeah.
And you had to know like which vaccine you were giving them. There was an NDC number, National Drug Code. So we had all of those things we had to figure out. And so
Yeah.
let's start there for a minute, Maya, because I know that you do a lot of work, expert witness work, for a lot of cases that involve drugs and keeping track of the pricing and all of that. So, what are some of the things that when you're doing your cases for some of these things that they're looking for you to capture in these reports? And when you're testifying, for instance, on this, what are they asking you?
Most of the time it's about medical necessity,
Mm-hmm.
right? And then a lot of times, like there was a case that I was dealing with for spinal, and then you have to look at, the guidance. What does the guidance say, and what does the documentation prove? And one of the cases I looked at, there was medical necessity that was questioned because the documentation allegedly was a template and not individualized for the patient. So when we talk about things that are updated and things like that, we do look to our major code certifiers, which are AHIMA and AAPC.
Mm-hmm.
But the problem is that you have to set a precedent. There has to be a precedent. You have to have documentation guidelines in place. If you're using a template, isn't individualized, can it be questioned by an attorney who questions the what's the word I'm looking for, the necessity for the treatment and if it was effective? So you get grilled, but I mean, if you stand by the guidelines and what it is currently and what the documentation states, it's not going to lie. And if anything, the documentation is going to support or not. If there was one thing that was off, then there's going to be everything that's off because it's not supported. And that charge for that service is not going to be supported.
Right. And so I wanted to kind of go over just that drug code, the NDC number, because a
Yes.
lot of times, I remember working in the office and you go to the provider or the staff back there and you would have to tell them, I need the NDC number. And they would always
Yeah.
push back. Why? Why is it important? And I think that it's really a disservice that we're doing to our organizations because we're not
Yeah.
giving our clinical staff training
Yeah.
on what the billing staff needs because they're the ones that have to give it to us a lot of the time.
Yes. Yeah.
Right? We'll talk about the JW and JZ as well, but the
Yeah.
modifiers. But I just think it's so important to talk about the NDC number and let's talk
Yeah.
about it, for instance. So, why is it so important to have that, Maya? Please tell us.
When you're dealing with the National Drug Code is what the NDC stands for. And the National Drug Code literally identifies the type of drug, the administration of the drug, and the milligrams of the drug. And without getting very granular, the NDC code represents the value of the service that's provided. It gives you the
Mm-hmm.
name, it gives you all of the information, and it tells you how much that code is worth. So think about the vaccinations, for example. When your child gets vaccinations, they have to have an NDC code that's associated with the value, right? If the value is not, or the NDC code is not identified, then you can't tell several things about the type of drug and if it was done via the VFC, vaccinations for children, or the chip. So, all of those things make a huge difference and when those codes are given and the source of where those codes are given. And the NDC code absolutely identifies that as it relates to care and all of that requires identification. So,
Right, exactly. And so let's just kind of talk about this for a second.
mhm, mhm.
When it comes to the NDC code, excuse me, let me show the right one here. There we go.
Yeah,
So
yeah,
sometimes we have to convert it to 11 digits versus 10 digits as it comes because some payers want 11 digits. So we have to know the formula, for
yeah,
example, and then where to
yeah,
put that 11th digit. So, for instance, we have to know how that works and where that digit goes.
Right.
for instance. And
Yeah.
so that's just one thing. And I'm not here to go into all the ins and outs on that, because that is part of our personal training we give to practices, for billing and coding. But I wanted to kind of just I'm giving you the basics today, guys, just the basics of what we have to understand when
Yeah.
it comes to getting this in the system correctly.
Yeah.
Everything we put in the system goes out to the insurance. If it's not correct when it leaves our system, it will either reject because they have a rejection in place. If they don't have this formula or this criteria coming over to them, it's an automatic rejection. Like
Yeah.
it won't even get past to the processing phase.
Yeah.
But let's say it gets past the processing phase, but now we've hit something where we ignore the medical necessity policy. We don't have the right diagnosis code that should be attached to that procedure code that we're submitting because they have a policy on it, right?
Yes. Yes.
So, for
Yeah.
instance, let's talk about these hyaluronic acid injections and why the OIG decided to do this. Because, again, they're paying out tons of money for these injections. Now, this was
Yeah.
back in I want to say 2012, 2013, back in the days when I was in the office every day before I was a consultant. And I remember it was a big deal if you had a Medicaid patient, because the physician assistant couldn't inject the patient, or sometimes they had to go to the pharmacy and get the medication because of a payment issue with the insurance. Blue Cross was another one. So they had to go to the pharmacy and get the drug and bring it into the office to be injected. So we could only bill the injection, the administration, not the drug. And it was really expensive. So if they were to purchase that drug in house and keep it on in there, it was like $1,300. Like, it was a lot of
Yeah.
money to purchase
Yeah.
this vial, right?
Yeah.
So
Yeah.
it was a
Yeah.
big deal to make sure the patient was covered. So again, I go back to the fact, do you understand the policy? Do you
Yeah.
understand what the policy is? Let's just go talk about Medicare, for instance. I'm going to pull
Yeah.
up the LCD policy
Mm-hmm.
for Medicare. And I think it's important that we understand the policy on this, because every policy kind of runs the same kind of formula, right? They have
Yeah.
basically what their indications are as far as what they feel is a covered indication. So if the patient has this diagnosis, if this treatment plan, they should be covered, right? I say
Right.
should be because they should be covered, right? So let's just say, for instance, we are going to be doing this particular injection. The one thing that we have to know is what is covered. Number one is symptomatic osteoarthritis of the knee. And they even are very clear in the policy: pain that interferes with functional activities such as ambulation and prolonged standing. So
Right.
guess what a CDI person, auditor, is going to want to look at? Did you tell us the diagnosis? Did you also give us that medical necessity, that clinical indicator of the ambulation that's being affected for this patient? They have OA. That's great. But how did you get there? What
Right.
did the patient tell you about this OA, this osteoarthritis of the knee, that led you to
Mm-hmm. Mm-hmm.
diagnose them with this? You can't just slap on OA onto the chart and it be okay. You have to
Right.
tell us how you got there.
Right.
And that's one piece of the puzzle, right?
Right. Absolutely. Just one piece.
Yes. Number two, the diagnosis is supported by radiographic evidence of OA. Again, do you have that? That's number two. Number three, biggest important thing that we are missing and why they are probably most likely auditing, the OIG is auditing this: trial and failure or contraindication of at least 3 months of conservative therapy. And they
Right.
list what they qualify as conservative therapy:
Right.
physical therapy, exercise, weight management, self-management programs, knee brace, cane. And then they also
Yes.
mentioned pharmacologic therapy, so NSAIDs, acetaminophen, oral, topical, whatever they've done medicinally
Right.
to try to prevent this from
Right.
happening.
Yeah. 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 I mean, and when you think about it, I think that's with any type of higher treatment. There has to be a progression and
Mm-hmm.
failed conservative efforts. And what I'm finding as an auditor is that the documentation is not always supported.
Hmm.
The physician just indicates that they need to progress in a different type of treatment, and they don't really think about that there's an LCD. They may need to get a pre-authorization, or that it's a higher drug cost. They just want to treat the patient, and they're not thinking about the logistics or the possibility that the patient might have an higher out of pocket expense because they're failing to document. And orthodocs are really notorious for not being real specific about what treatment is necessary, and the conservative treatment versus the more aggressive treatment. Because after that, you got to do, the total knee replacement. And
Yeah.
that's what you're trying to avoid. So you
Hmm.
have to show the progression. But if you're not showing the progression, because honestly, after that, I think the total knee replacement is going to be audited, because you're talking about the progression of treatment and the joint that's related to all of that. So when you think
Oh, and
about,
it is. It is.
yeah,
It is audited. Yes.
oh, well, then there you go.
100%.
Yeah. I mean,
It is audited.
so you have to think about all these different things and everything that's going to affect knee replacements, the progressive treatment, and the conservative efforts that have failed. And a lot of times that's what's missing in the medical record, which is why I'm going to really extend myself to say that they're going to get a lot of money back on this, because most of the time it's not documented.
And it's hard because our physicians, like we said before, sometimes they feel like they're held hostage by their EMR, and they're letting
Yeah,
their EMR work for they're like working for the EMR instead of the EMR working for them.
working for
So
them. Yeah,
and I've seen it. I've seen it 100 times over where they don't understand where to put things, and the system makes it almost impossible sometimes for them to edit and create their own system. Now, there's a lot of great systems out there that are customizable, but I will tell you from experience, there are some practices that don't want to go through another upgrade because of all the stress it causes, and they just stay with the same system over and every year after year that is outdated and does not have the functionality to keep up with the industry the way it's going. So,
right.
because of the stress of implementation, that's what prevents them from going into a more robust system that's going to help them increase their revenue and get it in faster. It's going to
Right. And I
improve the
think also,
documentation.
well, in addition to that, like, they don't optimize the usage that they currently have with the system that they're using because they don't want to be bothered. So
Yeah.
that's where we come in, and because they're not necessarily understanding how to use the functionality of what they currently have or what's actually needed, then it becomes more of a problem because they don't want to deal with any type of system improvement. And then you're dealing with medical necessity, or then you're dealing with outdated things that may not have been addressed in the older version of the system that you're currently using.
Absolutely. So then the next section that you come to normally on an LCD policy is the limitations. Okay.
Yep.
So they're going to tell you, okay, like you have these covered indications, but here's what you're limited by as far as how often you can do it. So they're very clear on FDA labeling, making sure that's inconsistent with that, obviously. But then initiation of a repeat series of treatment when at least 6 months have not elapsed prior since the prior injection. So in so many words, no more than you can't do it any less than 6 months in between. At
Right.
least 6 months have to be lapsed. And again, the thing oh my goodness, and us girls were and us auditors and consultants were like, laterality is so huge and specificity is so huge. And I just like when I see documentation where there is no evidence of laterality, I just feel like someone just was lazy that day or
Yeah, they dropped the ball.
they dropped the ball. And it happens. Maybe it's not laziness, it's just, they're so busy, but there's no reason to not have somewhere in the chart where you're talking about the side of the body that it's for. So we don't have to bill M17.9.
Right. I mean, and then you also have to think about the coding perspective. There are codes that are specific to laterality, and the modifiers should match the codes that are being billed for the service. I mean, that's,
Absolutely.
I just, I mean, that's well, because, we're on our soapbox, a soapbox moment, where you really, if you're using the modifier to reflect the service, you shouldn't have an unspecified diagnosis, and vice versa. Everything should be streamlined and it should match what's in the medical record for those types of services.
Yes. And it is true that there are some procedures that allow various diagnoses. But guess what? I'm going to read this right from the horse's mouth. A diagnosis other than OA is considered not reasonable, unnecessary, and not covered by Medicare. If they see anything other than M17.11, 12, whatever, not going to happen, guys.
Yep.
Now, there are variations of OA, but you want to read the policy specifically. Go to the article. So you have the actual LCD policy, which what I'm looking at is labeled L39260.
Yeah.
So I'm going to put that on here for you guys to look up on your own. So you have it. We want to make sure we're giving you the policy that you need. So this is the actual L policy, right? L39260. But if you scroll down in your policy, you're going to find another section that is the coding and billing document. And this is going to be what you're going to look at as far as the codes required. So when you go into the coding and billing, that's going to be A59030. Okay. So A59030 is going to be your article, right? So you click on that in your policy, right? You scroll down. It's going to give you the actual HCPCS codes for the drug, because that's what this policy is for. So, for instance, depending on which code you're using, there's various codes depending on the actual kind of hyaluronic acid injection you're doing. And so you need to know the code that applies. But once you do that, you're going to scroll down and you're going to find the actual diagnosis code. So M17.0, which is bilateral OA. You have 11, 12, and then you have, of course, post-traumatic and different versions there. But there's only like 10 codes available. So you don't have a lot of wiggle room with the codes here. No. And they're all going to be, guess what? The knee. That's what the drug's for. It's for the knee. So that's what the policy is going to state for you. Again, they want left or right. And then we have our fun modifiers, Maya, right? Our JW and our JZ. Yes. Not the Beyonce and Jay-Z, as I always like to say. It's a different Jay-Z, guys. Right. And this Jay-Z is causing all kinds of trouble since it aired last July. So as of July 1st of 2023, we should have been using it. And we were warned ahead of time it was coming. It wasn't like we didn't have clear warning, right?
Yeah.
So we were told this is coming, right? And so this is also on the policy. It gives all the applicable modifiers, including bilateral, LTRT, 25, all of that. But it does mention JW and JZ. So just as a brief overview, JW is for those single-use vials that are intended for one patient, right? And so the JW says, okay, I have this vial, I gave this amount to the patient, and I discarded this amount. That was that in effect since 2017.
Yes.
But then we weren't doing it right. We were just not figuring this out. And so then comes along JZ. And that is that you gave them everything, right? So either way, they want to know for these single-use vials, single use, one patient, you gave that patient the entire vial. They want to know that what you're billing them for is what you actually gave them, right? And there are caveats to some drugs where they do allow you to use what is normally a single-use vial on multiple patients. There's actual policies out there for some drugs. But overall, if you go on the CDC's website, they give you all kinds of instruction on what they consider a single-use or single vial. And so then they have multiple use vials and what the rules are there. They highly frown upon, and I say frown upon as in they don't want you to do it for safety reasons. They don't want you to give multiple patients a vial that was intended for one person.
Yes.
So okay. Yes, it's a cost thing too. I'm not going to lie. Like we know it's a cost thing as well, but they also have the safety thing in there as one of their policies that they recommend. And that means you do it when they recommend it. Right. You don't give it to more than one patient.
Yeah. I mean, you also have issues where the provider can't assign people to do the injection. It has to be done by the physician. He has to document. If he's documenting that he's doing it, then he's the one that should be doing it. It should not be teed off to the RN. It should not be teed off to the MA. He has to do the injection. And if it's not documented that they did not do the injection, that's another thing that the OIG is looking for. Mm-hmm. Was he in the suite? What did he actually do it? What did the note say? Did they document appropriately? Because certain drugs have certain classifications that cannot be utilized by ancillary staff.
And that's
Period.
the key too. You are 100% correct there. And I think that's the thing is like we may be used to using our ancillary staff for various things, but we have to know what we're doing. The medical necessity, but I mean, it's really just safety too. You know, if
Yeah,
you're going to be injecting into a certain area of the body that has to be targeted and specific, you have to be trained to do it. Um, so, I mean, doctors have gotten in trouble all the time for these kinds of things, and patients have been harmed
yeah,
because non-qualified people have injected them and they've suffered the consequences, and in some cases have lost their lives over it. And so it's a
yeah,
serious thing. Like it really is. So it's not just like, oh, I'm not going to get paid. It's sometimes it's a serious thing with some drugs, right? And
yes,
so, but we just want to make sure that we understand the significance of the payment as well. It's just what we're here for to talk about is the payment part. We all want to get paid, right? But we want to make sure it's done correctly so we can avoid risk to the organization and make sure that we are doing things above board, compliantly. And this goes back to communication.
yes,
Again, I'm always talking about communication these days, and we all know why. So communication is key. And that was one of the biggest pet peeves is that the communication wasn't there, and
right,
specifically for Jay-Z because and JW as well. We are not clinicians. We are not there. We don't know all the ins and outs of like we don't always have a list in front of us of which drugs are single use or whatever. So like we didn't go to medical school. We don't keep track of that stuff. Now maybe some people do, and that's great if you have the time for it. But a lot of people don't have time for that, and it's your job as a clinician to document that
yes,
this is a single use file and be very clear about it because it does affect reimbursement and it affects your possibility of getting audited.
right.
Because they're gonna know, especially if they know this drug is classified as this, they're gonna track that, and they are tracking it.
Yeah.
Modifiers are trackers. They're the big brother
If
of
they're
Medicare,
used
guys.
correctly, right? They have to be
Yeah.
used in order. Yeah, yeah. I mean, and you also got to think about, the documentation. And if your provider typically uses a lot of templates, a lot
Mm-hmm.
of those details about the amount of milligrams that are utilized. I once audited an ortho doc who documented that they used Kenalog and Toradol in the same session, where
Yeah.
if they're using a template and you're not really paying attention and you don't eliminate the things that are not relevant to that patient, you are also putting yourselves at risk. So you need to be
Mm-hmm.
sure that, or if you're an auditor or if you're a coder and you're looking at the documentation and it doesn't necessarily match, doc, you need to make sure that you're modifying this template to show what you gave or what percentage you gave of which drug, because again, if someone takes a look at this and it's not supported, then you're going to have a problem and they're going to take their money back. So if your doctor is using templates, make sure it's modified to represent what was actually done for that patient individually, because you're
Mm-hmm.
going to have problems if you do not, which is why this audit from the OIG is going to be really important, because it's going to show how much less attention is being paid and why they should take their money back.
Right. And so just for clarity purposes, it was announced August of 2024. So this month, it's brand new. And they do expect them to issue the results information for us in 2025. That's all we have right now. But that's why it's so good for supervisors, leadership. It's what we're here for, to talk to you leaders this season on what your responsibility is. And I know you're busy. I know you're really busy, but maybe you designate somebody in the coding department that's your eyes and ears. Like you don't have to be everywhere all the time, but you
Right.
need to be organized enough to have people you delegate things to so that if there's an issue, you trust that person in that department to say, hey, this came up. We should deal with this. This is a
Or
new
work
policy.
a
Yes,
work plan to
exactly.
identify some of the things, and that everyone should be aware of what that work plan is. So if something comes up, you know what's on the work plan, and it should be a targeted review of what's at risk. It's
That's a
called
great point,
mitigating
Maya.
risk. Yeah, yeah.
Absolutely.
So
Because I mean, the OIG has a work plan, and guess what? To follow your compliance plan, you should also have work plans because there's things that come up that aren't always in our policies. They just come up. Oh, we have to add this to a policy, but hey, we don't. We have to research this first. Let's put it on the next quarter's work plan of things to work on. So, for instance, I did a assessment for a CIA agreement, a corporate integrity agreement for an organization, and there was one of the things on my checklist that they didn't have at the moment. So when I talked to them, they had advised me that their organization has that on their next work plan. So that was part of the assessment. I reported back to the Office of Inspector General, which is my job to do that, and say this is on their work plan, right? It would have to do with cybersecurity policy because
Yeah.
it was relatively new at the time, so it was something that OIG was working on implementing as far as their structure. So it was kind of coming on the scene, and so yeah, they heard about it and they were like, let's do this. We're going to put it on the next set of things we're going to do. And so the next time we look at it, we're going to look at that policy when we audit the policies, and we're going to say, hey, have you done this?
Right.
So same thing with these injections. If you're an orthopedic practice, put it on your work plan if you haven't done it yet. If you haven't scheduled an audit of these services, it takes time to organize and to get that in place. So you maybe can't do it tomorrow, but make a plan that since the OIG is watching this, you're
Yes.
going to also be watching it, and you're going to designate internal auditors, and you might even go through the extra layer of defense and bring myself in maybe at Healthcare Inspired as an external auditor, because that's what I do all the time.
Right.
I audit these types of services. So, and then Maya comes in and helps with our reporting and the drug part. So, again, you have a great team behind you to help analyze your data to make sure that not only what your internal auditors found, but you can have extra backup, extra reporting in your compliance plan to show if they ever walk through your doors to audit you as the government, you can show them all of the audits you've performed over so many different years. And then, hey, we've implemented these changes as well. We didn't just do the audit and not change our policies. We
Right.
didn't just change the way we do things, right? So again, following through with that compliance plan.
Right. I mean,
Um,
I also wanted to say, I just wanted to add
yeah.
that if you know that the OIG is doing something that affects your practice,
Mm-hmm.
put it on your work plan and then do an audit, or do have a plan to do a pre-bill audit to make sure that it's necessary based upon the services that are affected by the work plan. And you can run statistics through your EMR. You should be able to run statistics through your
Mm-hmm.
EMR, see how many providers are doing the service and see
Mm-hmm.
what's problematic. You should have a process in place, and it should exactly mirror what the OIG is looking for so that you are not at risk. And if you are at risk, you can correct it before they even get to you, or even say that this is a problem. Oh, we already addressed it. We know this provider is this, and we know that we're doing this, and this is what we've done in to help correct it. But at the end of the day, you should be, or you're as a leader, you should be watching what the OIG is watching and have a plan in place to divert whatever that attention is and correct it before they even look at it.
Absolutely, absolutely. So, those are just some of the suggestions we have for policies. There's a lot of policies out there. It's not just cut and dry either. So, like I said before, when you don't have a policy, you make one.
Right.
That is your line of defense. So, for instance, there are some codes out there that don't have a clear guideline on them. There's even situations where ICD-10 doesn't have guidelines on a certain code set. If you work in GI, you know what I'm talking about. Your GI codes don't have guidelines whatsoever. Chapter 11 does not have guidelines. Other chapters don't either. So again, if you work in, like I'm a GI consultant as well. It's like when I go there, I'm like, well, you have to know medical necessity. You have to know clinical indicators. You have to understand that because there's no guideline on it. So we have to be clear. I used to always get on my providers for making me report R10.9 for every colonoscopy. And I said, one day it's going to change. There's no way these payers are going to get R10.9 and not make a policy. And I swear when that policy came out, I was like, oh, what did I say? And here it is. And then now that you have to get them to change their way of doing things because they're like, I have to tell you the quadrant of the abdomen? Really?
Hello.
Yeah. Because guess what? I asked them this in the audit too. I said, do you treat your patients different if the pain is in the right upper quadrant versus the right lower quadrant?
Oh yeah.
Because of the organ that's there? Maybe. Yeah, you do. You do treat them differently. I know you do. So again, why wouldn't you want to put that in the documentation? It's not even about reimbursement. I mean, that's part of it.
Right, right.
It's about what's true.
Right. I mean, anytime you're using or defaulting to an unspecified code when there's a specified treatment in the
Hmm.
documentation, you're always going to put yourself at risk.
Oh,
So try
yes.
to avoid that unspecified codes. If there's granularity in the documentation, the granularity should also be specified in the code when used. The payers are always going to come back, and that's one of the key indicators. If you're using specified codes for a specific procedure, especially when you're using modifiers, then that's going to be a red flag all day, every day.
Absolutely. And speaking of compliance, guys, we are so excited. Again, we're going to keep, putting this in your face. We are so excited about the Inspired Compliance Seminar coming December 7th. 7 to 8 CEUs, depending on, what we have going on. But we have about 7 to 8 CEUs available, and some great speakers. I mean, we have Rhonda Buckholes, we have Don Self, we have the amazing Susan Wahlberg, who literally wrote the book on compliance, and we'll be giving away a copy of her book, her latest book on technology and compliance, at
Oh,
the
that's
conference. So
yeah.
you want to attend to have a chance for that. Christine Hall will be there to talk about telehealth compliance. We have Sonal Patel. We have Betty Hovey, who's going to be our auditing compliance guru. And we have Melissa Kirshner. We have Keisha Wilson. We have Kimberly Jolvet Williams. It's an all-star cast, and I'm really excited that we get to have these great people for this next conference. And it's just something that we felt we needed to do, because the more I get asked to come into practices and do EMR optimizations, the more I find that it's not just EMR optimization that I'm going to be doing. And it's amazing how many practices don't have a compliance plan. Like, they don't even know they needed one.
Or they don't understand revenue integrity as it relates to a compliance plan or
Yeah,
policies related to such. I mean, and it's like it's all intermingled. And if you don't understand one component, you're going to miss everything. So,
exactly. So we're just here to help you reduce risk. We really want that. I just had a conversation with one of the surgeons that I code for and audit for in plastics, and he's just such a great guy, like a great physician, and he really just wants to do things right. And he honestly doesn't go in contract with insurances. He's out of network with all of them, but he still wants to make sure that he doesn't create any risk for himself. So, like, for me, like, I know my scope for that project. I am not compliance for him. I'm only tasked to stay in my scope as coding and providing the codes that are applicable for documentation. I give him documentation tips. But I always advise my clients, if it's out of my scope for this project, I do recommend that you get a healthcare attorney, if you don't already have one, that understands your state. Because sometimes they don't realize, if they don't bill federal payers, if they don't bill Medicare, they're opt out of Medicare, they still fall under state regulations. So
yeah,
I always say, if I'm not tasked to help you with that and provide that service, I highly recommend you get somebody that does. If you want me to help with that, we can. But I'd always advise them to get a healthcare attorney to make sure that they understand what the risk is, and what they can do, what they can't do. Because
right,
there are legitimate ethical physicians out there who really want to do what's right, and they just don't know, and
right,
they just keep going along. They want to see patients, and they sometimes just assume that their leaders and their administration is handling this stuff, and then something comes up and they have no idea why
right,
their license is in danger, or
right,
why
right,
they
right,
have these audits coming. They have no idea, and they're like, what?
right.
So
Yeah, yeah, yeah. I mean, and I also have to say that though, and no disrespect to any healthcare attorneys out there, but all healthcare attorneys don't know coding. They
it's
don't
true.
know. So when you have a healthcare attorney, it's advised that you partner with a compliance team once, or a compliance consultant once you get a healthcare attorney to advise you of the contracts.
Mm-hmm.
It's important to have a partnership in that regard if you're going to be advised legally. They can advise you on contracts, but they do not advise on compliance when it comes to coding. So that's something that every practice who is not actively involved with a healthcare attorney, that they be involved with a compliance professional as well.
Absolutely. It's just good practice. So I think that it's good for us to just contemplate these things, and think about the risk. Now, we're going to be putting out more education So, special announcement, season 4 is coming. We have one more episode before season 4 starts in September, and it's the compliance connection. So,
Yeah.
next season is all going to be on compliance. You will
Yes.
find that we will sprinkle in all of the elements of an effective compliance plan all the way up to our conference. So, we're going to be giving you a lot of those throughout the next few months until December hits, and we're going to talk a lot about coding. We're going to pick on certain specialties, primary care, which is Maya's domain, and then I will be talking surgery with orthopedics, general surgery, ophthalmology. We're talking about, of course, ENT, one of my other main specialties. And if you're going to be in Norfolk, Virginia on September 16th through the 20th, I will be at the Ascent Conference in Norfolk, Virginia, along with other experts like Barbara Kabouzi, Sean Weiss, Robert Lyles, and among others. So I'm excited to get to be on stage among some of those great, great people. So if you're going to be in Virginia, check that out. And I also want to shout out to Dawn Self and Carlene Dietrich because they have an amazing, amazing billing course, really an all-inclusive course, understanding how payers are responsible for what they do. And a lot of time we don't hold payers accountable
Nope.
for following their own policy. So Dawn knows the law like nobody's business. Carlene knows these advantage plans, commercial plans like nobody's business. And so I've had the privilege of being able to be at conferences with both of them, and they know their stuff and they're amazing. So I am taking their course as a consultant. I'm taking it upon myself to be educated by these people because they are so knowledgeable to grow my own career. So I want you to know, as a consultant, we don't stop learning. We go and we take and we put ourselves back into that because we've realized how awesome education is, and we want people to benefit from it.
Right.
So,
You don't
I
want your
mean, why
knowledge
wouldn't
to
you?
be dated, right? You don't want your knowledge to be dated for 3 years ago when the laws have changed the year before. So it's
Mm-hmm.
always a good job as coders and as consultants to be current with the current technology, current with the current laws. That's what our job is, and that's what we should be really in cognizant with when we're consulting with other practices.
Absolutely. So I think it's really important just to remember that and just, do yourself a favor and don't think of education as an expense. Think of it as if you don't have it, it's a liability. It's
Yeah.
a liability not to have it.
Yeah.
So, again, thank you for listening to the show today. We are, of course, one more episode till season 4. We thank you for always supporting the show. And again, we will see you next time on the Healthcare